Hi, this is Dr. Rybinnik. Today we will discuss hydrocephalus and the disorders of CSF circulation. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. I have no relevant financial conflicts to disclose. This case was modified for teaching purposes. The objectives for this talk are as follows. We will start by introducing a clinical case. What are the clinical features suggestive of hydrocephalus? That question will be answered in the second section. We will then learn the imaging findings of hydrocephalus, review circulation of CSF and localize the area of obstruction, and discuss the differential diagnosis. We conclude with a brief discussion of available treatments. Here we go. We begin with a case of a woman with headaches. Oh, I have a headache. It might be a tumor. It's not a tumor. It's not a tumor at all. This is a reference to the movie Kindergarten Cop, but quite fitting here. We have a 42-year-old highly educated woman who is generally healthy, except for prior history of childhood meningitis. She developed 3 months of progressive headaches. These headaches have a particular quality of worsening when coughing and bending down. Associated with the headaches is a slew of other symptoms, including difficulties concentrating, forgetfulness, non-lateralizing gait difficulties, whooshing in her ears, and progressive blurry vision. During her clinic visit, the vital signs are normal. She's fully oriented but responds slowly to your questions and has diminished short-term memory. She was able to recall 2 out of 3 items after 5 minutes. We didn't see papilledema on eye examination, but the left eye did not abduct, which is the definition of lateral rectus muscle palsy. There's no weakness or sensory loss, and the base of her gait is narrow. Her gait was generally stable, with mild difficulties when asked to walk tandem. So, considering this 42-year-old woman with history of meningitis who developed subacute progressive headaches, difficulties concentrating, memory loss, non-lateralizing gait difficulties, and left lateral rectus palsy, what is the differential diagnosis? Well, these are symptoms of mass effect. So we should first consider a space-occupying lesion, a neoplasm or abscess, idiopathic intracranial hypertension, pseudotumor cerebri, hydrocephalus, and cerebral venous sinus thrombosis. Since hydrocephalus is on our list, now is probably a good time to review its clinical presentation. In adults, hydrocephalus generally presents with signs of elevated intracranial pressure, headache, nausea and vomiting, ocular signs such as papilledema and visual obscurations, presumably because pressure waves are transmitted along the optic nerve sheath and transiently compromise optic nerve perfusion. So the optic nerve doesn't get enough blood flow transiently, and you get a blackout of vision. Elevated intracranial pressure can cause cranial nerve palsies, especially abducens nerve palsy. Well, that's a peculiar sign. Why is the 6th nerve so special? The theory is that with increased intracranial pressure, there's a downward displacement of the brainstem, and that displacement stretches the 6th nerve, compressing it against the petrous ridge of the temporal bone. So abducens nerve palsy is a so-called false localizing sign. The problem doesn't necessarily originate in a 6th nerve. Instead, in this case, a global increase in pressure gets transmitted to the 6th nerve. Finally, cognitive impairment, urinary difficulties, and gait instability complete the list of major symptoms of hydrocephalus in adults. These are signs of frontal lobe dysfunction. Ventricular expansion tends to be maximal in the frontal horns, so descending frontal lobe fibers for motor and micturition pathways are affected the most. But in children, hydrocephalus presents very differently. Infants get fretful and listless, feed poorly, and vomit frequently. These are non-specific signs of any illness and not just hydrocephalus. But over the first few months of life, the head enlarges, sutures separate, and the normally soft fontanelles become tense. A child may exhibit developmental delay and the so-called sun-setting phenomenon. Here's a video courtesy of Dr. Hawk. Look at the eyes. The upper eyelids are retracted and the eyes tend to turn down. The infant cannot look up, so the sclera above the irises are very visible. This happens because the pressure waves transmitted by the CSF are directed towards the midbrain, and the midbrain contains the vertical gaze center. Okay, but our case is an adult, and she's experiencing headache, visual obscurations, abducens nerve palsy, cognitive impairment, and gait instability. What is the next best step in the diagnosis? That's a very relevant question, Dr. Rybinnik. Well, thank you, Dr. Rybinnik. I thought so. That's why I asked it. I'm just trying to keep you awake. Let's talk about the diagnosis of hydrocephalus and the dreaded dilated temporal horns. As for many disorders of the central nervous system, the best diagnostic study is a brain MRI. Here's a normal example. This is a FLAIR image, fluid attenuated inversion recovery, basically a T2 with CSF subtracted. This is an axial cut through the basal ganglia. The patient is facing the top of the screen with the patient's left on your right. Here's the frontal horn of the lateral ventricle, with the head of caudate laterally. Head of caudate is separated from the lentiform nucleus by the internal capsule, which incidentally also separates the thalamus from the lentiform nucleus. Third ventricle exists between the thalami, and the insula is on the outskirts. This next slice is from the same patient but lower down, through the midbrain. Midbrain helps us locate the temporal lobe, and the temporal lobe contains the temporal horn of the lateral ventricle. Note how it's small and slit-like, barely visible. And one more establishing view, this time a T2 sagittal cut through the midline. This patient is looking to the left side of the screen. Recognize the corpus callosum, with the lateral ventricle behind it. Fornix, a part of the memory pathway, forms the roof of the third ventricle. And the fourth ventricle is between the brainstem and the cerebellum. Now this patient has ventriculomegaly, enlarged ventricles. But how did I know that? Well, let's be scientific. Look at the maximal width of the frontal horns and compare that with the maximal diameter of the skull. This ratio is called the Evans ratio. As you saw in the previous example, normal frontal horns are generally small and certainly occupy less than 1/3 of the maximal skull diameter. That's not the case here. Unfortunately, as a marker, the Evans ratio is a rough approximation and at best tells you the ventricles are large, and large ventricles are not necessarily due to hydrocephalus. Feast your eyes on this image. Ventriculomegaly? Probably. But is it hydrocephalus? The cortex is very atrophic, so the ventricles are probably enlarged just to fill in the extra space, so-called ex vacuo dilatation. That's not hydrocephalus. That's not too much fluid in the skull. You can see that Evans ratio alone is not enough. We need more reliable markers. Let's convince ourselves that this example is truly hydrocephalus. We have decided that the ventricles are dilated. Note the bright signal surrounding the ventricles. It's diffuse and smooth. That bright signal is fluid. Under pressure, CSF is pushed across the ependyma, ventricular lining, and this transependymal flow is a marker for hydrocephalus. Transependymal flow certainly helps when it's there, but what is the most sensitive indicator of hydrocephalus? This is an axial slice from the same patient through the midbrain and the temporal lobes. Look at those ginormous temporal horns! Temporal horns of the lateral ventricles are normally tiny and slit-like. Big temporal horns are the most sensitive marker of hydrocephalus. Beware the prominent temporal horns. They will ram you. And now take a look at this patient's sagittal scan. Localizing structures are labeled. Lateral ventricle is dilated, and so is the third ventricle. By all accounts, this patient has hydrocephalus. What's the culprit? Here it is, a pineal tumor, but more on that in a bit. Our patient received an MRI of the brain. The images are FLAIR axial cuts through 3 different levels: the frontal lobes, basal ganglia, and the midbrain. Our patient is looking towards the top of the screen, and her left is on our right. Does our patient have hydrocephalus? Pause the video and analyze the images. The frontal horns are certainly at least 1/3 of the maximal skull diameter, so there is ventriculomegaly with dilated lateral ventricles, third ventricle, and the temporal horns, although that one is not as obvious. The icing on the cake here is the periventricular hyperintensities, representing transependymal flow of cerebrospinal fluid. The CSF is clearly under pressure. And for completeness' sake, here's a T2 sagittal image with the patient facing the left side of the screen. The lateral ventricle is dilated, and so is the third ventricle. But the fourth ventricle appears normal. So, dilated ventricles, especially temporal horns, transependymal flow, our patient was clearly diagnosed with hydrocephalus. I didn't show you a post-contrast sequence, but there was no abnormal enhancement to suggest a mass lesion. The next step on the road to treatment is to identify the area of obstruction and the actual pathological cause. This brings us to a review of ventricular system and the circulation of CSF. Raise your hands if you remember arachnoid granulations. Anybody? Who am I kidding? I can't see your hands. Hey, you're not any better either. You're the one raising your hand when nobody can see them. Anyway, CSF is produced in the choroid plexus inside the ventricular system at a rate of about 20 cc's per hour. Considering that the total volume of CSF is approximately 150 cc's, CSF is refreshed about every 7 hours, or 3 to 4 times a day. A typical lumbar puncture drains about 30 cc's of CSF, so the patient can replenish that volume in just over an hour. Arterial pulsations help drive the CSF from the lateral ventricle, through the foramen of Monro, into the third ventricle, then through the cerebral aqueduct, into the fourth ventricle, and then through the foramen of Magendie and Luschka, to the subarachnoid spaces around the brainstem and the spinal cord. The CSF circulates through the subarachnoid space, down the spinal canal, and over the cranial convexity before being reabsorbed by arachnoid granulations into the intracranial venous sinuses. What would happen if we block various parts of the ventricular system? Say there's a mass obstructing the foramen of Monro. Yes, lateral ventricle will enlarge under pressure. What if the cerebral aqueduct is obstructed? Right again, the third and lateral ventricles will enlarge. And what if there's a lesion obstructing the foramen of Luschka and Magendie? This lesion may be inside the fourth ventricle or outside of the ventricle in the posterior fossa. Yep, all ventricles proximal to the occlusion will enlarge. The fourth ventricle, cerebral aqueduct, the third ventricle, and both lateral ventricles. Easy. Alright, so where's the obstruction in our patient? Here's our patient's T2 sagittal cut through the midline with the patient looking to the left. The landmarks are labeled, but this time you will have to identify the ventricles and judge their size. Pause the video while you review the imaging. Let's see. Lateral ventricle is dilated. Third ventricle is dilated. Fourth ventricle is normal. So I agree with you that this lesion must be in the cerebral aqueduct. What is the disorder that is causing the hydrocephalus? Let's not get ahead of ourselves here. We need to talk about the differential diagnosis first. Okay, you might know the answer, but just be cool, okay? Let everybody else catch up. Theoretically, hydrocephalus can be caused by overproduction of CSF or underabsorption, obstruction to CSF flow. Overproduction of CSF as a cause of hydrocephalus is exceedingly rare. For example, choroid plexus tumor can overproduce CSF, but it usually causes hydrocephalus by obstructing CSF flow anyway. So let's focus on obstruction.
May I have your attention, please? All clinically significant hydrocephalus may be considered obstructive. All clinically significant hydrocephalus may be considered obstructive. Thank you for your kind attention.
There are generally two forms of obstructive hydrocephalus: non-communicating and communicating. Non-communicating implies a blockage of the normal CSF flow through the ventricular system and the subarachnoid space. We've just discussed this mechanism in the last section. Non-communicating obstructive hydrocephalus can be caused by a colloid cyst blocking foramen of Monro, aqueductal stenosis, and lesions in the posterior fossa. We will use these three disorders as prototypes for our discussion, but there are of course other neoplasms, abscesses, and cysts that can cause obstruction. Communicating hydrocephalus is mechanistically distinct. It implies a problem with CSF reabsorption. There is an increase in intracranial CSF content without a gross anatomic lesion obstructing flow. We're talking about subarachnoid hemorrhage, or other cases of extensive meningeal disease like infectious or carcinomatous meningitis. Normal pressure hydrocephalus also falls in this category. We'll discuss these disorders in a moment. Before we move on to the actual disorders, a little disclaimer here. The non-communicating versus communicating distinction is convenient for learning, but in truth the line between these two mechanisms is often blurred. As I mentioned, all forms of true hydrocephalus are obstructive, at least at some level, but the obstruction is virtually never complete. So hydrocephalus may have features of both non-communicating and communicating mechanisms. Disclaimer over. Let's get to the actual disorders. First up is the colloid cyst. Colloid cysts are non-malignant mucin-filled lesions. But just because colloid cysts are non-malignant, we will soon see that they may not be benign. They arise from the roof of the third ventricle, and they're frequent enough to warrant attention. 20% of all intraventricular masses are colloid cysts. They grow and obstruct foramen of Monro, acting almost like a ball valve or a plug. This obstruction can be so sudden, causing acute hydrocephalus, rapid herniation, coma, and even death. Colloid cyst looks like this on imaging. This is a flare sequence, axial cut, with the patient facing the top of the screen. Lateral ventricles are certainly dilated, and the culprit is in the middle. Here the cyst appears hyperintense because of increased fluid content, but these cysts are generally of variable brightness on T2 flare. The higher the proteinaceous content, the darker the signal. This is another flare axial cut, but lower down through the midbrain and the temporal lobe. Notice the dilated temporal horns. What did I say before? Beware of prominent temporal horns. And finally, the T2 sagittal slice with the patient looking to the left of the screen. As expected for a foramen of Monro lesion, lateral ventricle is dilated. Third ventricle is not visible here and is probably normal. The fourth ventricle is normal as well. So that's a colloid cyst. Next up, aqueductal stenosis. Stenosis can have many causes, but congenital is a prominent one. It is the most common cause of congenital hydrocephalus. The obstruction to CSF flow is at the level of the aqueduct of Sylvius. That causes enlargement of lateral and third ventricles with a normal fourth ventricle. This is a slow process, so the symptoms of hydrocephalus are usually insidious. And patients can present any time from birth to adulthood. Let's take a look at an example. This is a T1 sagittal cut through the midline, and by definition, the patient is looking to the left side of the screen. Lateral ventricle is large. Third ventricle is dilated too. Fourth ventricle is normal. Where's the lesion? That's right, cerebral aqueduct in the dorsal midbrain. Posterior fossa lesion is another common cause of obstructive non-communicating hydrocephalus. Why? Well, posterior fossa is a confined space, so any mass lesion, large cerebellar stroke, hemorrhage, or tumor, can compress and obstruct the fourth ventricle. You may see signs of brainstem compression, reduced consciousness, ataxia, cranial nerve palsies. Acuity of these symptoms depends on the mechanisms. Hemorrhages expand rapidly, for example, and patient may have these symptoms early at the presentation to the emergency department. Ischemic strokes can take hours to days to swell, and compared to strokes, tumors usually create mass effect much slower and present subacutely or chronically. Regardless of the mechanism, the end result may be the same: hydrocephalus, brainstem signs, and unfortunately increased mortality. Here's an example. Non-contrast head CT, axial cut through the pons with the patient looking up. The fourth ventricle certainly looks compressed and displaced to the patient's right. What's the cause? A wedge-shaped hypodensity corresponding to an acute ischemic stroke in the territory of the posterior inferior cerebellar artery. So what would you expect the third and lateral ventricles to look like? Absolutely. The entire ventricular system will be dilated. The third ventricle is large in this patient, and the temporal horns of the lateral ventricle are prominent. Here's another example. Where's the fourth ventricle? I'm having a hard time finding it. It's completely obliterated by the mass effect from the cerebellar hematoma. What about the third and lateral ventricles? Both are dilated, same as in the previous case. And the final example. This case features a mass in the fourth ventricle that obstructs foramen of Luschka and Magendie. This mass is an ependymoma, a common primary CNS tumor in kids under the age of 3. This time, the fourth ventricle is enlarged. So is cerebral aqueduct, the third ventricle, and the lateral ventricle. And you can see the telltale signs of hydrocephalus here. What are they, by the way? I always forget. That's right, prominent temporal horns and transependymal flow. This is a classic presentation for a fourth ventricle ependymoma. So we reviewed 3 entities: colloid cyst, aqueductal stenosis, and posterior fossa lesion. But the moral of the story here is that in a patient with ventricular megaly, first assume non-communicating obstructive hydrocephalus and look for a lesion causing obstruction. What did I just say? Look for a lesion causing obstruction. Look for that lesion. Do it. Do it now. Okay, you get the point. It's an Arnold Schwarzenegger themed talk. Speaking of the cause of obstruction, let's get back to our case. Just to remind you, our patient is a 42-year-old woman with a history of meningitis who developed non-communicating hydrocephalus with dilated third and lateral ventricles but normal fourth ventricle. There was no abnormal enhancement to suggest a neoplasm. Have you figured out the patient's problem? Pause the video if you need to. You're right. This is aqueductal stenosis, probably caused by meningitis in her case. This so-called bulk theory of hydrocephalus is over a century old, and it's still useful because it's fairly straightforward. But the disease process causing communicating hydrocephalus is tougher to understand, and it's not really explained by this theory. We mentioned previously that it's a disorder of CSF reabsorption. But it's not as simple as saying arachnoid granulations are damaged, therefore CSF reabsorption is impaired. Because guess what? Majority of CSF reabsorption actually happens in the capillaries and not in the arachnoid granulations. To explain communicating hydrocephalus, we need to update our knowledge with the relatively new hydrodynamic model of CSF flow. This is a crude drawing of the major intracranial compartments. Intracranial arteries are in pink, veins and venous sinuses are in blue, capillaries are between the arteries and veins, and the subarachnoid space is light blue surrounding the tan-colored brain tissue. The intracranial components are contained by the skull, with the major opening, foramen magnum, at the bottom of the screen. At the beginning of systole, systolic pulse wave carries blood into the intracranial vessels. Brain and vessels are compliant and elastic, meaning they can expand to accommodate the increasing pressure, kind of like rubber bands. So arteries expand, and the bigger the pipe, the slower the flow. 'Cause, physics. Blood flow slows down as it gets to the capillaries. At the same time, the pressure from the systolic pulse is transmitted to the entire brain in the subarachnoid space. This pressure causes a CSF wave, which increases flow in the venous sinuses. That's how the venous blood drains from the head. Slowed arterial flow eventually gets to the brain capillaries, and this causes a slight brain expansion. This normal amount of pressure allows fluid to exit the capillaries into the interstitium. There's a rapid diffusion and mixing of the interstitial fluid and CSF across the surface of the brain. It's really impossible to tell the difference between these two fluids. So the brain capillaries and not the arachnoid granulations actually play the greatest role in absorbing CSF. They are the ones that regulate and maintain fluid homeostasis in the brain. The end result is that the brain pulsates in tandem with the heartbeat, and we can see that with a specialized MRI sequence called phase-based amplified MRI. Now, say a patient suffers a bout of meningitis. Inflammation decreases compliance of intracranial structures, especially vessels. arteries do not expand during systole. They behave more like rigid tubes. The high pulse pressure is transmitted directly to the capillaries. This increased stress leads to less CSF being absorbed into the capillaries, and the ventricles dilate. So the problem in communicating hydrocephalus is not a blockage somewhere in the ventricular system, no, but a decreased compliance of the brain and vessels. Now, things are much more complicated than that, but this is a very good start. A perfect example of a disorder causing acute hydrocephalus is subarachnoid hemorrhage. Nearly 1/3 of subarachnoid hemorrhage patients develop hydrocephalus because blood in the subarachnoid space is neurotoxic. When hydrocephalus does develop, it's usually acute and can be seen in the first hours after bleeding onset. Clinical signs of hydrocephalus, like headache, lethargy, nausea, vomiting, are unfortunately indistinguishable from the signs of subarachnoid hemorrhage itself, so we often need to rely on imaging. And finally, a common theme here. When present, hydrocephalus usually worsens outcomes. On to the imaging. Here's a non-contrast head CT, axial cut on the left and sagittal cut on the right. What is the most sensitive indicator of hydrocephalus? That's right, dilated temporal horns, signs of dilated lateral ventricles. You can also see diffuse hyperdensity in the subarachnoid space. This is subarachnoid hemorrhage. By the way, subarachnoid blood causes chemical meningitis, but there are other kinds of meningitis. Meninges can be invaded by bacteria, fungi, and even neoplastic cells, so-called carcinomatous meningitis. Incidence of hydrocephalus is variable and, of course, depends on the cause. For example, only about 5% of adults with community-acquired bacterial meningitis get hydrocephalus, but that number is 10 times higher in patients with tuberculous meningitis. The more robust the inflammatory response, the thicker the exudate that covers the brain, and the more likely you are to see hydrocephalus. Here's a gross pathology example of a pneumococcal infection generating a thick layer of pus. Acuity also depends on the cause. Hydrocephalus is usually acute with bacterial infections, but can happen months after tuberculous infection. One thing's for certain is that hydrocephalus is potentially deadly, so we should treat it very aggressively. No labels this time, you're flying solo. Does this patient have hydrocephalus? How do you know? Absolutely. Dilated temporal horns? Check. Dilated lateral ventricles? Check. Transependymal flow? Check. And what's the cause of hydrocephalus? These are FLAIR images, and CSF signal, which is normally bright on T2, is subtracted on FLAIR, so subarachnoid spaces should be dark. But here, they're bright. This has to do with the proteinaceous exudate mixing with CSF in a patient with meningitis. This patient was proven to have tuberculous meningitis. The final example is normal pressure hydrocephalus. This is a disorder of older adults. Just like with other causes of communicating hydrocephalus, there's decreased CSF absorption because of decreased vascular compliance. The clinical hallmarks that you memorized in med school, such as gait difficulties, dementia, urinary incontinence, are non-specific. We talked about these being signs of frontal lobe dysfunction from ventricular enlargement. But what is specific is that symptoms usually improve after high-volume CSF drainage by lumbar puncture, and the diagnosis relies heavily on documenting that improvement. If patients don't get better after CSF drainage, they probably don't have NPH. Here's the same patient before and after lumbar puncture. The gait is slow and the patient's feet look like they're glued to the floor. This is so-called magnetic gait. The legs are weak and take significant effort to lift. The gait is so much better after treatment. The one challenge with diagnosing NPH is that brain atrophy is prevalent in older population, so you need to distinguish hydrocephalus with NPH from ex vacuo ventricular megaly with an atrophic brain. This distinction is supremely important because it predicts how well a patient will respond to hydrocephalus treatment. Let's take a look at an example. Here are two FLAIR images, axial cuts through the basal ganglia. One of these is from a patient with NPH, and the other is from a patient with dementia of another cause. Now, this one's a bit advanced, but which one is which? 50-50 chance of getting it right. Nicely done. Yes, NPH is on the left and ex vacuo is on the right. On the right image, ventricles are dilated in proportion to severe cortical atrophy. The bright signals around the ventricles are small vessel ischemic changes, or mini-strokes, and the patient probably has vascular dementia. The patient on the left may respond to CSF drainage. The patient on the right will not. And speaking of treatments, what are the treatment options for hydrocephalus? How can we help our patient? Well, long-term treatments of hydrocephalus are all about removing the obstruction and diverting CSF flow. First, whenever possible, remove the cause of obstruction and restore the normal flow of CSF. We talked about the importance of identifying the cause of the obstruction. If a tumor is identified, for example, it needs to be surgically resected. But a resectable cause of obstruction is not always identified. So time for Plan B, diversion of flow. It's especially important in cases of acute hydrocephalus. Think patients with subarachnoid hemorrhage. Lumbar puncture can drain off some CSF, and is a reasonable diagnostic step in stable patients with chronic hydrocephalus. Think NPH. It's not the best of ideas in acutely ill patients who may have mass effect and increased risk for brain herniation. If you have a patient with deteriorating level of consciousness and evidence of elevated intracranial pressure because of hydrocephalus, immediate CSF diversion with an external ventricular drain is a much better option. In this procedure, a catheter is placed through the non-dominant frontal lobe into the frontal horn of the lateral ventricle. But long-term, CSF shunting remains the standard of care. The most common type of shunt diverts CSF from the ventricles to the peritoneal cavity, so-called ventriculoperitoneal shunt, or VPS. A patient with acute hydrocephalus may start with an external ventricular drain, which may need to be converted to a shunt if they can't tolerate weaning. A patient with chronic hydrocephalus may get a shunt directly after responding to CSF drainage by lumbar puncture. Shunts are not benign procedures. Shunts can get occluded or infected. Shunts can also overdrain CSF, causing low intracranial pressure, which may present with headaches and subdural hematomas. So procedures like endoscopic third ventriculostomy and choroid plexus cauterization offer an alternative to shunting. A patient has aqueductal stenosis? No problem. Let's make our own opening in the ventricular system. So an opening is made in the floor of the third ventricle, enabling direct communication between the third ventricle and the prepontine cistern. Making an opening to bypass the obstruction is part of the puzzle. At the same time, destroying choroid plexus decreases CSF production. So combining these two procedures yields better results than ventriculostomy alone, especially in children younger than 1 year. These procedures are promising, but shunting still seems to be better for now. So according to the bulk flow model, ventriculostomy bypasses an obstruction, and choroid plexus cauterization reduces CSF production. In the hydrodynamic model, ventriculostomy acts to create a pulsation absorber, and the choroid plexus cauterization reduces the amplitude of the pressure wave. Effectively, with these two procedures, the compliance of the entire system is improved. So, in conclusion, our 42-year-old woman with a history of meningitis developed subacute, non-communicating hydrocephalus due to aqueductal stenosis. She was treated with ventriculoperitoneal shunting, and her symptoms improved. Alright, you spent about half an hour of your time. What did you learn? Patients with CSF circulation dysfunction present with clinical signs and symptoms of increased intracranial pressure. Headache, papilledema, gait ataxia, abducens nerve palsy, enlarged head circumference, sunset sign, etc. Hydrocephalus is mainly diagnosed with imaging, dilated ventricles, prominent temporal horns, and transependymal flow. Obstruction can be localized by noting the dilated structures. Aqueductal stenosis, for example, results in dilated lateral and third ventricles. All hydrocephalus is obstructive. Causes of non-communicating hydrocephalus include colloid cyst at the foramen of Monro, aqueductal stenosis, and posterior fossa lesions, especially with mass effect on the fourth ventricle. Communicating hydrocephalus results from reduced compliance with inflammatory, hemorrhagic, and infectious lesions. Diagnostic studies can help identify the cause of obstruction, and hydrocephalus is treated with the removal of that cause to restore normal CSF flow and/or CSF flow diversion, especially when the cause of obstruction cannot be identified. Ventricular peritoneal shunting is still the standard of care, but endoscopic third ventriculostomy and choroid plexus cauterization are attractive alternatives. And that's all for today. Thank you so much for your kind attention, and I'll see you next time. Bye.